greeting to all of you. It's a great pleasure for me to share this lecture with you today. I want to say that through many years in SER, our clinic has brought great happiness to many families around the world. And one of the most important allies in this work are you, the doctors and the patients who trust us and our clinics. And in this joint work, one of the most relevant processes are the controlled ovarian hyperstimulation and the endometrial preparation in cycles of IVF and ICSI. And this will be the topic to talk about in this lecture for you. You know that infertility is considered by the WHO like a disease for several years. And in my opinion, it is a puzzle composed of several pieces that we must know to perfection. And we have four main pieces for this puzzle. The first one is that we need mature oocytes. The second one is the good sperms. The third is the good embryo quality. And finally, we need a good endometrial receptivity for having good chances for implantation rate. As always in medicine, you know, everything starts with a good diagnosis, followed, in this case, by the ovarian hyperstimulation, the egg retrieval, the sperm collection, the egg fertilization, and finally, the embryo transfer. It looks simply, but it's a complex process that needs a lot of attention and a lot of care in every single step. What are those steps? And I want to give you these four main points. The first one is the pituitary block, because remember that in a normal natural cycle and in an IVF cycle, the estradiol levels are rising with the stimulation, and we need to avoid the LH surge because if we have ovulation or premature ovulation, it could affect the final result of the cycle. Then we need to choose between the GnRH analog, agonist or antagonist, and some cases we can use progesterone for make this block. The second step is the ovarian stimulation, and it's very important to select the ideal gonadotropins and the ideal doses depending of each patient. Remember that we need to make a very care ultrasound control in all the process. Third, we need to select the mechanism for make the oocyte maturation triggering. And in this specific point, we have two options. We can use the GnRH agonist, or we can use the HCG. And finally, we need to make the embryo transfer, and this is the fourth step of the process. And we need to decide if we will make a fresh embryo transfer or a frozen embryo transfer. Remember that all of these steps are conditioned by the maternal age, the ovarian reserve, and the comorbidities of the patient. You have, for example, a patient with a breast cancer or thromboembolism that could affect the result of the process. Okay, let's talk about the first step, selecting the medication for blocking the LH surge. Historically, we have been used agonist or antagonist, and most recently, antagonist GnRH for this effect. But which is better? And the right answer is depends of the patient type, because we can classify the IVF patients in three main groups. The first one are the normal responder, the second one are the high responder, and the third are the poor responders. And in according to this classification, we could select the ideal protocol. In 2017, Dr. Wang published this meta-analysis, and he concluded that the outcomes in normal responders are very similar, comparing agonist versus antagonist when we analyzed the life rate, for example, in this forest plot, but the incidence of ovarian hyperstimulation syndrome was higher in the agonist group. And this is an important fact for us because we want to avoid the OHSS in every cases. Meanwhile, in 2017, Dr. Lambalk published this meta-analysis evaluating the stimulation effects depending of patient type. And the conclusion was very similar than Dr. Wang. The oocytes number was similar. The quality of the eggs are very similar. The pregnancy rate either. But again, the OHSS incidence was lower in the antagonist group. And this is very important because remember, if we have any little risk of OHSS, maybe the better option is to consider the use of antagonist of GnRH. Okay, but if we talk about the poor responders, despite the controversial evidence available, some authors, as for example, Dr. Rakakis and his group, support the use of agonists in poor responders. It seems that the flare effect and the stimulation with this type of medications give us a better result in this specific group. But I insist, this could be a tool, but is not a fact proved currently. And recently, we have been used progesterone for this pituitary block, but the question is when we can use progesterone. And the answer is in all of cycles that we know previously will go to frozen embryo transfer. Because if I use progesterone from the early follicular phase, it will affect the receptivity of the endometrium. Then the results until now with the emergent evidence are at least similar than agonist or antagonist of GnRH, but remember only in cycles that will be frozen. Okay, the second step is to select the right gonadotropin and the right dose of this medication. And we have two options. We can use urinary or recombinant compounds. The other selection is the molecule, FSH or HMG, but I want to make easy this step. And if we read the guideline published in 2019 for the ESHRE, we can conclude that the results comparing FSH versus HMG are very, very similar. In some cases, for example, in poor responders, we could use some adjuvant therapies. In this group, we can find the LH, the CoQ10, and the DHEA as the most important options. Maybe these three medications have been shown better results in patients with low ovarian reserve. Again, there is not a strong evidence that supports the routinary use, but we can keep in mind these type of strategies. Third, we must decide the ideal moment and the ideal medication for triggering the oocyte maturation. And there is an important risk that we should considering at this time, and remember, is the OHSS. When we have an average follicle size between 16 to 20 millimeters, we will be ready for the triggering. And we have two options. We can use HCG or we can use GnRH agonist. And the HCG is a better option when we have a low risk of OHSS, if the patient has 1 to 15 follicles, and if we are considering the fresh embryo transfer. By the other hand, if we have a patient with a high risk of OHSS, or if the patient has 15 to 20 follicles or more, and if we are considering the frozen embryo transfer, maybe the triggering with agonist of GnRH will be a better option. After the trigger, we must make the oocyte extraction, and that will be 36 hours after the triggering. And the goal of this triggering is only restarting the maturation of the oocyte. Okay, once we have the eggs in the IVF lab and we have the embryos after the culture, we should define if the embryo transfer will be fresh or frozen. If we decide for the fresh option, blastocyst transfer is the first and the ideal choice. Currently, the embryo transfer in cleavage stage, for example, day 2 or 3, are very, very uncommon. We prefer to make the embryo transfer on day 5 because we know that the implantation rate is higher comparing with the stage of cleavage. Okay. Then recently, the technique of freezing all has become more frequent. For example, when we have a patient with a high risk of OHSS, or when we are going to perform PGT, or for example, if we have an endometrial asynchrony, or simply to avoid the high levels of estradiol during the cycle, trying to improve the endometrial receptivity. Then, which is better? What is the better option for the patient, fresh embryo transfer or frozen embryo transfer? And in 2021, Dr. Massenbrook published this review in a Cochrane database, and it seems that there is not a statistical difference between frozen or fresh in normal responders. And this is important thing because we are talking about normal responders. In this specific type of patients, it seems there is no big difference between the fresh or frozen embryo transfer. Then, if we take the option of frozen embryo transfer, we have 3 different protocols for the endometrial preparation. We have the natural cycle, we have the modified natural cycle, and finally, we have the artificial cycle. Okay. In 2013, Dr. Cullen shared these results in this meta-analysis comparing natural versus modified cycle, and he didn't find a difference between these 2 protocols. Okay. Recently, some papers have been shown an advantage in natural cycle comparing with artificial cycle, with similar live birth rate, but lower hypertensive disorders during pregnancy. And this is an emergent evidence, but it seems that maybe that would be the ideal way in a near future. Okay, now let's go from theory to practice. After all of this evidence, I want to give you a useful tool for the management of these patients. In this slide, I want to show you how we make the ovarian stimulation. Remember that this process begins in the early follicular phase, maybe day 1 or 2 of bleeding with an ultrasound. And it's important to make an antral follicle count because according to this number of follicles, we could decide about the right medication and the right dose for the stimulation. After the beginning of the gonadotropins, we need to make an ultrasound control maybe on day 5 of the cycle. At this moment, we can see the evolution and the response of the ovaries. And we could decide if we make any change in the dose of the medication. If everything is going well, we will see the image similar than this ultrasound here. This is a good response of a patient. We have in 1 ovary 1, 2, 3, 4, 5, 6, 7, 8, 10, maybe 9 or 10 follicles. This is a good response. After that, around day 10, of stimulation, we need to make the triggering for the oocyte maturation. At this moment, we prefer that the patient arrive to our clinic. It means that you can make all the first part of the stimulation between the day 1 and day 8 or 9 before to traveling to Colombia. On day 10, we will see the patient and we will decide the medication and the ideal moment for the maturation trigger. And 36 hours later, we will make the oocyte pickup. And if we will make a fresh embryo transfer, remember that the ideal moment is on blastocyst stage. It means around day 5 or 6 of the beloved. Okay, but if the choice is to transfer frozen embryos, we can use the natural cycle protocol, where we do follicular monitoring, and once we have a follicle around 16 to 20 millimeters, we trigger the ovulation and transfer on day 5 of progesterone, okay? Then remember that I told you before that the natural cycle seems to be the ideal way for the embryo transfer, but the other alternative, and perhaps the most used due to its easy performance, is the artificial cycle. It begins on day 21 of the menstrual cycle with the application of a GnRH agonist that will block ovulation for the following month. We wait for the menstrual bleeding, and at that moment, we begin progressive doses of estrogens until we achieve an endometrium thickness around 8 millimeters or more. At that time, the patient must arrive to their clinic. We start the progesterone and we'll make the embryo transfer on day 5. Okay, this image that you can see here is a good blastocyst and is the ideal goal for us. Remember, the transfer on blastocyst stage is the best option. Okay, that's a lot. Thank you to every one of you for your attention, and I hope that in this lecture, short, but I prefer to make a short but useful presentation for you, you acquired the practical tools for your routine use. Thanks again, and I hope to see you soon. Bye.